we've got a couple of papers that are really interesting. They report on what it looks like to recover from a medical illness in TV and movies. We see people wake up, get up, walk away, and there's sort of rebound. And so friends, family, and even if, as we've talked about, medical and psychological experts not really sort of appreciating that this isn't a bounce back situation. Physically, mentally, this takes a toll.
Coming home, and I don't think this is uncommon, my family was like, yay, you survived, woohoo. To me, the hard journey was just beginning.
Welcome to Find Empathy, your go-to podcast for insights on medical and health psychology. We explore the mental health impacts and strategies for living well with a serious medical condition, chronic illness, and/or disability. Whether you have lived experience, support someone who does, or are a mental health or medical professional, this podcast is for you. Today's episode was prompted by Dr. Kirsten Harrell, a psychologist and fierce advocate wanting to increase awareness and education on a very important topic called post-ICU syndrome. Let's get started. Kirsten, thank you so much for wanting to create this project about post-ICU syndrome. Can you share just a little bit about yourself and your background, and then we're going to go into hearing more about your personal story?
Sure. I am a psychologist and unfortunately have not been able to work for a number of years due to illnesses. But when I was working, I kind of focused on folks with physical illnesses and anxiety and PTSD, which interestingly enough is now all the things I'm dealing with.
What brought you to working with people with chronic illness?
I initially, early on in my life, wanted to be a physician. And then I kind of had a change and thought that I'd rather kind of work more with people who had physical illnesses and help them deal with the emotional and psychological impact of that.
And your work life became personal. Can you share more about that?
Yes, and unfortunately, it started even before the ICU with chronic illnesses that took me out of work for a bit. And then I was recovering and then got sick with the flu, sepsis, ARDS, and ended up in the ICU on a ventilator for 3 weeks and in the hospital for a total of a month. And that really changed me, changed clearly the trajectory of my life. I hadn't been able to work at all since then. And it was 6 years ago, and I'm still dealing with some of the post-intensive care syndrome effects.
In addition to Kirsten, we have two PICS experts joining the episode. First, we have Dr. James Jackson. He's a research professor at Vanderbilt University Medical Center. He is an internationally recognized expert on the effects of illness, including long COVID, on cognitive and mental health functioning. He is a licensed psychologist and pioneer in the investigation and treatment of post-intensive care syndrome, or PICS. He is the co-founder and director of behavioral health at the award-winning ICU Recovery Center, one of the world's first comprehensive clinical resources devoted to diagnosing and treating survivors of critical illness. He serves as the director of long-term outcomes at the Critical Illness Brain Dysfunction and Survivorship Center, CIBS. The CIBS Center is widely recognized as a leader in advancing knowledge, education, and models of care for people affected by acute and long-term brain dysfunction following critical illness. Dr. Jackson, who goes by Jim, defines post-ICU syndrome for us.
PICS is a term and a construct that people are referring to a lot more regularly than they did. It wasn't that long ago that you would bring it up with a doctor, a patient would bring it up with a doctor, and they would have no idea what you're talking about. I was recently an expert witness in a case, and a lawyer actually knew what it was. And one of the treating physicians of the patient that I had engaged knew what it was. People know increasingly what it is. What it is a syndrome that is characterized by mental health concerns or cognitive problems or physical disabilities or some combination of those that have developed after a critical illness. Some of us think it should be called post-critical illness syndrome because it's not necessarily the intensive care itself that is driving these problems. It plays a role, but it's also the critical illness. It's the notion that you're doing fine, perhaps, before you were critically ill, and you develop brand new problems you didn't have before, or perhaps you had challenges before, but after intensive care, they're meaningfully worse. In a nutshell, is post-intensive care syndrome. Looks different in different people. It has a little bit of a different natural history. For many people, it has a bit of a chronic flavor. Kirsten's alluded to this. I think it does become a lot like a chronic illness. It doesn't completely go away. It ebbs and it flows. And one of the great challenges clinically, of course, is helping people learn to flexibly adjust to what is effectively a new normal. And that's a important clinical challenge, and it's a hard thing.
Can you share a little bit about your background and your experience with post-ICU syndrome?
I can. It's really interesting. We had a patient, I could get into the weeds, so I'll try not to do that. But we had a patient that we got to know very long ago, one of the first patients that I had engaged in my research work here at Vanderbilt. And she sent me an email and she said, when you met me, she sent me an email yesterday. She said, when you met me, I was 49 and now I'm 71. And I was 34 and now I'm 56. So I've been at this for 22 years plus. And at this is working at the intersection of cognition and mental health in ICU survivors. I came to Vanderbilt, did a residency, didn't have aspirations to be a researcher as such. Actually got a fortune cookie at a Chinese restaurant called August Moon and cracked it open, and it said, you will prosper in the field of medical research. And I thought, that is oddly specific. I lost the fortune, but I do have a picture of it. And that sort of empowered me to pursue this path, which is a path of treatment and investigation. If you look at the numbers of people like Kirsten, the numbers of people with post-intensive care syndrome, I think it's fair to say that that number in North America alone every year is in the millions, huge number of people. And they fly under the radar screen tremendously. I think it's fair to say that there are people with lupus and MS and, I can go down the list, heart disease, various kinds of cancer, conditions that in some cases are far less prevalent than post-intensive care syndrome, and they get far more attention. Good for them, right? We're not trying to take the attention away from people with these problems, but trying to point out that we have a little bit of a marketing problem. We have a bit of a branding problem. People aren't quite as aware as they should be of both the magnitude of post-intensive care syndrome and of the prevalence. It's incredibly prevalent.
Going back to you, Kirsten, I want you to kind of walk us through your personal story and then we'll ask questions along the way.
Okay. I remember on a day I was feeling pretty good. I started coughing. I was up that entire night, literally coughing nonstop. In the morning, got up and said to my partner, I need to go to urgent care. So we went there, and that's the last thing I remember for a week. I apparently for that week was going back and forth to the emergency room and being sent home. I had like 104 plus fever. So I think I was just maybe a little delirious. On the maybe third visit to the ER, they sent me from the small community hospital to a little bit of the bigger community hospital. And I was admitted right into ICU. I do remember being there, and I remember them talking to me about being intubated, and that was terrifying to me. I didn't really know much about what that meant to me. It meant, oh boy, this is maybe the end. Having to sign all the papers and do that was a pretty terrifying experience. They had a guitar player in the ER room that I remember, which was really lovely. That's one thing that kind of stuck out. I do not remember a whole lot of my ICU experience, which is fairly typical. I was in a medical coma for most of the time. However, there was a period in the middle that they brought me out. Unfortunately, I aspirated and then got worse, and so went back into the medical coma. The time in the middle when I was awake, I was a little more aware and I could communicate by writing and was a little out of it, but knew what was going on. By the time I woke up the next time when I was extubated, I was completely out of it and having delirium. The ICU delirium and hallucinations for me were some of the most traumatic parts of the ICU stay, just absolutely terrifying experiences that felt so real to me. And as from the rest of the people I know with PICS who experienced delirium, they all say the same thing, just a very sticky experience. And to me, it felt like a real lived trauma. During one, I felt like I had been kidnapped and was in an experimental hospital away from my family for the whole time, and I couldn't figure out how to get out. I had another one where I thought there was some kind of strange, evil magic people trying to get to me. Very scary experiences. Some of the biggest challenge for me post-ICU is dealing with the impact of the ICU delirium. Lots of other traumatic feelings in the ICU. Not being able to communicate was for me probably one of the hardest things and most frustrating. And as time progressed, initially I could write. Then it got to the point that I would try really hard to write. It was so difficult. It felt to me like climbing a mountain to write a couple words or sentence. And I would show it to my family or staff and they couldn't read it. And I remember feeling so angry at them. Are you kidding me? I just completed this Herculean challenge of writing it and you can't read it? Can't you just try harder? After I got out and I looked at it, I realized, there was no way to read it. It was basically gibberish. But in my mind, I just felt like, well, they're just not trying, and I just tried. And so that was horrible for me, feeling so completely helpless. I can't move, can't breathe on my own. I can't communicate. Just completely at the mercy of the people around me. And that, I will tell you, is a very, very scary place to be.
Dr. Jackson jumps in here with a question for Kirsten.
Kirsten, I don't know if you agree with the premise of my question, but the premise of my question is that the lay people, and also I think a fair number of mental health professionals still have some pretty woody ideas about what constitutes a trauma, and they associate trauma often with combat and sexual assault, quite rightly. But I think many of them don't really have space necessarily for the idea that a critical illness would be a trauma. First, would you agree with that? And second, what would you say to someone who would say, well, that delirium, those experiences weren't real. So, how could that be traumatic? What would you say about that? And what would you say to people who would say, I'm not sure this is a trauma?
Yeah, that's actually one of the biggest motivating pieces for me to do this is that I think as you said, the lay population, but also mental health and medical professionals don't necessarily understand that piece and how those experiences, those hallucinations are just as clear and crisp in my memory, actually far more clear and crisp than any of the other memories from the ICU. And to me, they truly feel like lived experiences. And then I will also say that it is confusing even to those of us who've experienced it, because you come out and you think, okay, I know that didn't happen. And yet I'm having flashbacks to it, intrusive memories, all the signs of trauma and PTSD. And it was a little difficult for me, even as a psychologist, to accept that and understand that. I think as your body is there in an absolute fight for your life while you're experiencing these things, I think that helps contribute to it being experienced as a trauma that is as valid as any other trauma and needs it needs a little bit of a special nuanced approach, I think, because people do understand if they've been through war or a sexual assault or something like that, that they've experienced trauma. But there are a lot of patients who come out and they themselves don't understand why this is so impactful to them. So having a mental health provider who understands that and can help them understand that, yeah, it was not a real thing. You now know it's not a real thing, but at the time, your brain and your body didn't understand that it wasn't real.
I would imagine too that you're a psychologist who has an understanding of what trauma is and what these intrusive thoughts are, and sort of a framework to put some of this in, which doesn't necessarily make it less impactful. But I could imagine somebody without that background might experience it in a maybe more intense way. I don't know. Could you share your thoughts about that? Like your experience versus somebody who might not have that framework to put it in?
And my experience in talking with other PICS survivors, I think I did have a little bit of a easier, I guess, time accepting, oh, okay, yeah. And finally, when I recognized it, but it took me a bit even. And I recognized, okay, this is PTSD. But I know that there are plenty of people who don't recognize that. And then they think, oh my gosh, something is really wrong with me. And quote unquote, I'm crazy. And just truly don't understand that it could be PTSD because they think I wasn't in war, or I wasn't a sexual assault. There must just be really something wrong with me versus I have PTSD.
Here, Dr. Megan Hosey joins the conversation. Dr. Hosey, a psychologist that practices in the medical ICU, is an assistant professor at Johns Hopkins in the Department of Physical Medicine and Rehabilitation. She specializes in the psychological adaptation to critical illness survivorship, and health psychology interventions. Dr. Hosey also participates in the Outcomes After Critical Illness and Surgery Research Group. Here, she shares a little bit more about the symptoms common to post-ICU syndrome.
So I think that Kirsten and Jim have done a wonderful job fleshing out what PICS is. The term came about in about 2012 when many of our ICU survivors, we've got a lot of folks who previously would not have surviving now because of the advancements in critical care. And these folks use their voices to say, things are not the way they were before. They describe the symptoms that Jim and Kirsten have been describing. And so a post-intensive care syndrome came about as really, like Jim was saying, a marketing tool. So it's not a specific diagnosis that you'll find in the ICD-10. It's not something that somebody will write in a medical chart. And the reason is because, again, that's more for marketing. And because we also want to acknowledge what a diverse array of outcomes people can have when they have post-intensive care syndrome. Kirsten's done a gorgeous job of talking about PTSD symptoms. Jim highlighted how criterion A, which is that you have to have had threat of death or harm. And Kirsten's story is so important because there's two components of this for our ICU patients, right? She told you stories about how she was intubated and could not communicate when she was experiencing severe symptoms like breathlessness, perhaps, or it's really hard to describe how hard it is to lie in bed, not being able to do anything for yourself, particularly at night, particularly when you're confused about where you are or when you are. So that inability to communicate in a life-threatening situation could potentially, we could debate about whether that meets a criterion A. So there's all of that. You're fighting literally to stay alive. And then B is these delusion experiences. Again, I just want to normalize and validate the types of things Kirsten was describing. You know, the hallmark feature of inattention or of delirium is inattention, and it happens in 80% of people. Certainly people who are older or people who have had a chronic illness might be more at risk for ICU delirium, but we see this in 26-year-old marathoners. This could happen to about 80% of people who are mechanically ventilated. So we don't want people to think that this is rare or uncommon. And it's also very common for people to describe things like Kirsten described. The hospitals become torture chambers, experiment organizations, routine peri-care, so cleaning people up, can turn into sexual assaults. Last week, I had a woman who's now 30, but when she was hospitalized at 27, thought that she was having toy planes inserted into her arms. And so when she returned to the ICU to sort of get a sense of what she had, she realized it was butterfly needles that had been inserted, but her brain, in a place where it could not attend to everything that was going on due to illness, due to medication side effect, due to being in a strange environment, thought that it was a toy plane being put in her arm. All of these are very common types of hallucinations and delusions, and again, can happen in anybody. So what's the long-term outcome of that? We have PTSD. Anxiety is the most commonly reported, even out to 5 years symptom. And for that can manifest is somatic hypervigilance, or just waiting to see what next happens to your body and not really having such an easy time telling what's a normal symptom or an uncomfortable symptom versus what's a harmful one. Anxiety can also look like new onset panic. It can look like catastrophic worry about what happens to me next. Depression is the second most common. And also, it's not uncommon for all of these symptoms to overlap. Depression, often people reporting sense of helplessness, hopelessness, worry about not getting back to the life they had before, describing difficulty finding meaning in life after they've been discharged. And certainly a lot of folks describe irritability with the lack of function that they had before. We've got a couple of papers that are really interesting. They report on what it looks like to recover from a medical illness in TV and movies. We see people wake up, get up, walk away, and there's sort of rebound. And so friends, family, and even if, as we've talked about, medical and psychological experts not really sort of appreciating that this isn't a bounce back situation. Physically, mentally, this takes a toll. So those are a lot of the mental health symptoms. And then certainly physically, we know people can take a while to recover their musculoskeletal function. We know people have ongoing sleep disruption, chronic pain, and fatigue that can be fairly disabling as well.
We turn back to Kirsten. She reacts to some of the facts that Dr. Hosey just shared.
I was relating so much to what Megan was saying. And one of the things that kind of stuck out to me that I have thought about, maybe because of my background as a psychologist, that is different in ICU survivorship trauma versus some other types of trauma is that the threat came from inside, not outside. And that can make it really difficult when you do feel symptoms. And I have an immune deficiency. So for me, any new illness initially really caused a lot of panic for me of, oh my gosh, here we go again. And it's you don't trust your body necessarily or your mind because of the delirium. So it's this very odd thing that that trauma all came from inside yourself, and you can't get away from that. Coming home, and I don't think this is uncommon. There was definitely still some confusion, and my family was like, yay, you survived, woohoo. To me, the hard journey was just beginning. Trying to recover physically, the first year was really focused on the physical recovery and trying to regain strength and stamina. I could not even get up from my couch without help. I couldn't. Took, I don't know, over a month before physical therapy released me to walk with my walker by myself because I would fall backwards. So much was focused on the physical that I did not begin to really recognize and understand some of the cognitive and psychological impacts until after that first year. And initially, I was thinking most of it was cognitive, and I could tell, and again, because of my background, it was mostly executive functioning type of things that were problematic. And I had a very low frustration tolerance. And that's when I was really noticing something was wrong, because I remember one day I burned my toast and I got so upset I threw the toast. And I was like, whoa, where did that come from? That is not me. And I was like, I think there's something going on here. And I knew nothing about PICS at the time. So I asked my PCP and my neurologist. Neither of them had any idea. Just said, yeah, maybe still just dealing with some cognitive issues from the ICU, but really no help. So I had to start kind of looking things up myself and found PICS. And I was like, oh, okay. So other people do this. And that began to really help me get a framework for what was happening, which did help because I did what I think a lot of people do. And I'm like, oh my goodness, this is something is just weird with me. And I remember early on after that first year, we was going to go visit family who just had a baby. And I freaked out, just completely had a panic attack about leaving my home. And that was absolutely when I was like, okay, I clearly am having some PTSD here because I am just panicked to leave, and tried to seek help with therapy. And the first several therapists were actually unhelpful, unfortunately, because they had no idea and really struggled with what it looks like to have that intersection of PTSD and mild cognitive impairment. I think that really throws some therapists who don't have any background or understanding of that, and they don't know what that means, or you can get misdiagnosed and just not helpful in the treatment. So it took me, I think, 5, therapist before I found someone who, and she didn't know about PICS, but had enough trauma experience and willingness to learn that it worked out. But that's a piece that has motivated me, because I know a lot of people go to therapy, they have somebody who doesn't understand, and as we've all said, it's not an ICD code, it's not in the DSM, it's not diagnosable, and they hear it's not real. And so then they think, oh, see, it's not real. This person doesn't believe me. Why should I keep going? And that is, and every time I hear that from PIC survivors, it just hurts me in my soul, because as a psychologist, I'm like, oh God, that is terrible.
And harmful in many
and
ways.
Harmful, yes.
Yes. Jim, I'd love for you to jump in and just share any comments you have from what Kirsten has shared, as well as what would a good treatment look like?
Kirsten said so much, and a lot of it was really astute. One of the first things she said that stood out to me, she talked about the trauma. And again, I would note that, as Megan said, this isn't all PTSD, right? This is PTSD and anxiety and depression in the mental health arena. It's executive dysfunction and often cognitive problems that mimic a brain injury in the cognitive arena. It's physical disability. So it's not just trauma, but what Kirsten mentioned reminded me of Don Edmondson at Columbia Medical School, who has developed this model of PTSD, medical PTSD, if you will. And he points out in this somatic model that trauma for people who are medically traumatized often resides in the body. It's not external, as Kirsten noted, it's internal. And he notes that most trauma is backwards looking. Something happened in the future, or in the past, rather. But if you have a heart attack and you're carrying your heart around with you, you could have another heart attack, right? If you have a immune deficiency and that lands you in the ICU, that could happen again. So not only is this trauma residing in you, it's not behind you, it's also in front of you. So I think that makes it uniquely challenging, as do the cognitive problems that are so common that happen in perhaps 30% of people or so. And we see that overlay a lot, where people's ability to be as insightful as they were, to make the connections as adroitly as they did, to be as cognitively flexible as they might have been, they're not, right? Because they're cognitively impaired now. So they're trying hard to address these issues, in some cases with one hand tied behind their back, because they've got cognitive challenges. And I think Kirsten would agree. There are a lot of therapies, seems to me, that work well with ICU survivors with PICS. If I had to write the name of one on the whiteboard behind me and draw a circle around it in red, it would really be acceptance and commitment therapy. You know, that's not the only therapy that you can use. Certainly for PTSD, there are any range of things. I like the exposure therapies a lot. We have a simulation lab here at Vanderbilt where I imagine we could take patients to. That sort of opportunity exists to bring people back to the ICU, to look at the diaries that they wrote. It's exposure therapy. But what I love about acceptance commitment therapy for these patients is the acceptance part. It's more complicated than that. But this idea that I've got brand new challenges and I'm not who I was, and I don't love who I am right now, but can I find a way to accept it? Can I find a way to even embrace it? Can I live in accord with my values and find a way to live a meaningful life? That, I think, is the key and the ticket. Again, it's not so simple, right? It happens over years, but our patients who do better rather than worse are patients who find a way to make some meaning out of their experience. For Kirsten, and I know Kirsten because she's in a support group that I have led here at Vanderbilt, I think she's finding some meaning, and I don't want to speak for her, by wearing this patient advocate hat and doing it beautifully well, right? She's finding some meaning. And I think that's the opportunity for our patients. And we try to lay the gauntlet down with them and say, how can we help you find some meaning in this? If you can find some meaning in this, doesn't make it perfect, but it makes it better. I think the other thing that's really important here, and again, Kirsten's in a support group, is so often with PICS, there's this profound isolation, right? And it's born out of, man, you weren't in the ICU. You didn't have these delusions that I had. You don't understand my story, so I'm not going to tell it. And isolation is really harmful, right? And I think when our patients are in isolation as opposed to in a healing community, they struggle more. And when they are joined with other people in community, they do better, not surprisingly. So I think the onus is on us to try to figure out how to engage our patients in community, to try to find ways to set them up for success in building connections with other people that will help facilitate their healing.
Thank you. That was a lot of really helpful information. As you were talking, I had this thought of I was never trauma trained, but I have background in CBT and ACT. And I had this initial reaction of, should I be getting trained in certain types of trauma interventions if I were to work with somebody that had PICS? And so I wonder if other people who are listening to this might have a similar kind of reaction, especially Kirsten, as you shared that the therapist that you ultimately landed with did have that background.
I think it's important to at least be trauma informed and have some understanding of that. However, I will say the first few therapists that I tried did have some, but their background was more in like EMDR, which for me just was not helpful. Far too intense, far too fast, and made me worse. And they weren't willing to have some flexibility to understand that was not helpful for me. And again, that mixed with the idea that they had no understanding of the mixture between the cognitive impairment and the emotional health issues. And I've had many people all along the way say, well, you seem fine. I don't see any cognitive problems, which is, again, something that's very harmful. You may not necessarily see them all the time because they can be subtle. Sometimes they're not. And when I get really triggered and the cognitive impairment gets worse, it can look like a mess. But other times it's very subtle and I can function as I'm talking here, but I cannot sustain it. I cannot sustain the cognitive functioning for long. Like after this, I will be wiped out. But people don't see that. So they don't understand, oh, yeah, there really is an issue there.
I think Kirsten made a really great point, which was she saw these providers who maybe were beautifully well trained in EMDR for all I know, and yet it wasn't effective. And I think I'm an advocate of empirically validated therapies and using them the right way, certainly. And I also reject this sort of reflexive, sort of simplistic, hey, let's just give her a little EMDR and she'll be fine, right? Let's just give her, however many sessions we're going to give her and we'll send her home, she'll be fine. I think that the challenges that ICU survivors have are encapsulated, right? And reside in this broader experience that's really complicated. So I do think you need to be thoughtful and know your way and be competent in the treatment of trauma. But I think if that's where you stop, not sure that you're going to serve your patients that well. I think a lot of good treatment to me with our ICU survivors is basic. If you remember, there were books that were popular for a while. Everything I Needed to Know About the World I Learned in Kindergarten, I think was the title, maybe something like that. So the rapport building, hey, Kirsten, I get you. I'm not going to minimize this. This is really difficult, right? It must be really hard to have your life uprooted. And what does this mean to you? And how can I walk through this with you? And how can I invite you to use your resources to recognize that you can do really hard things. Those sorts of emphases, I think, are hugely helpful in addition to the trauma, because at least in my experience, it is a little unusual that we find someone with a neatly delineated case of PTSD after the ICU that has real clear edges, right? I mean, it's often a package of things, and I think it prevents simple approach to treatment. Megan Hosey, what do you think about that?
I would 100% agree. I think what both Jim and Kirsten are also alluding to is we don't have a set of literature about critical illness survivorship or a lot of treatment specified for people who've experienced medical trauma. And so I think what we know is that there are like baskets of things that we can pull from that would be effective, and not a lot of it's been tested. I agree with Jim. I think starting with your basic skills is what's most important. Validation, normalizing the commonness of a lot of these experiences, exploring, like Jim was saying, maybe starting from an ACT perspective where you're looking at purpose, values, things the person think are important in themselves, and then working through some of the triggers that we know can prevent full engagement in those things. And that can look like trauma treatment, that can look like subjective units of distress for people who are familiar with that concept from CBT. It just start where you are and build. I think that's part of the work that we're trying to work toward in the ICU. So we're moving towards a humanization of the ICU environments, which means how do we slow down, learn who the person is, who they were before they came into the ICU, and start to incorporate that into their ICU experience, particularly because we don't want to keep telling people they should wait to be who you are until later, wait to be doing things until you're better, because there's no capstone for that. And also some of the humanized or like some of the incredible work that people at Vanderbilt like Jim and Wes Ely have been doing to just the basics of ABCDEF bundle. So these are things like incorporating family regularly, making sure people get opportunities to be awake and alert and participating. These are really basic things that we think could change the course of critical care. And so there's a lot of people really invested at starting early at making sure that we're centering the person and hoping that maybe that can mitigate some of these longer term effects.
I'd mention one quick comment. I had a patient, it's been a year or two ago now, and he came to see us at the ICU Recovery Center, and he had been in a ICU diary program at Vanderbilt, and Megan's very familiar with those because they use them at Johns Hopkins, and basically a nurse typically writes down various experiences that a patient is having contemporaneously, and a patient can look at them later, and often these ICU diaries become quite dear. And that was true with this patient. He had this ICU diary, and when I came to see him, he said that he carried it around everywhere he went in a bag. He had like a workout bag that you'd put in the locker room, and he carried this little diary everywhere with him. And even though he carried it with him, he never opened it and didn't want to open it, but felt he should open it. And, our task therapeutically was, okay, let's get it out of the bag, right? Okay, we're not going to read it today, but let's just acknowledge it, hold it in your hands. Let's put it on the nightstand next to your bed, right? And then, a few sessions later, let's actually open it, right? And now let's actually start reading it. And we did that. And it was quite transformative, and it was impactful, right? And it was helping someone in a structured therapeutic way lean into these fears, realize that they didn't need to shut him down, realize that he had more agency than he thought. And that exposure exercise, if you want to call it that, became really transformative. So I think opportunities are there if we look for them. And hopefully one of the goals of this, one of the effects of this lovely podcast. And really one of the things that Kirsten hopefully will accomplish as she continues to educate and educate and educate is just to put this on the radar of psychologists, because it's frankly not often on the radar, right? It's on our radar, but it's not on the radar of many of our colleagues or our physician colleagues. So, my goal is if people could just start asking questions about this of their patients, I think that'd be a great place to start. And Kirsten, we're so proud of you at Vanderbilt. We watched you grow and lean into hard things, and we watched you transform into a leader as you've impacted the lives of dozens of people in this beautiful support group that you're part of. And we're really grateful for you. So well done.
Thank you. Thank you. And I hope you could allow me just to back up from that just for a moment to address a little bit of something that Jim said about how the trauma can go forward as well. I was making progress because my ICU was 2018. And then when COVID hit, I went into a mental health crisis because the respiratory virus for me, because of my immune deficiency, was like worst nightmare possible. And so seeing all the coverage and hearing the words and all that, it was just like living in constant triggering state that really just spun me into a pretty bad and dark place with anxiety and fear and depression. And I kept calling it, I would ping pong between the trauma vortex and what I called pit of despair, where I would just be triggered and having my own flashbacks to ICU. And then I would go into kind of a depression and the despair. And to me, that felt, as I was sinking in it, it was like a dark fog. And initially I could say with my own background and skills, okay, that's depression talking. Those dark thoughts, those aren't real, it's depression. But then it was like the fog just would completely envelop my brain. And suddenly I believed those dark thoughts. And I did have suicidal ideation, and it was pretty intense, certainly in the beginning of COVID. But still, medical procedures and all of that are very difficult for me now, and they are for many people with tics. Having to go back into a hospital or any kind of medical procedure is very anxiety provoking. So I just wanted to throw that piece in there. As far as the work with my therapist, I think a little bit that, like Jim has alluded to, validating and understanding that, yes, your cognitive impairment is real. I don't always see it, is how she would frame it, but I believe you that it's there. And when I do see it, combined with the anxiety, it would be like, again, my description was I would have a thought, and it felt like somebody took all the words and just mixed them all up. And I'd have to spend time trying to sort them back out and put them in the right order, and then figure out how to get those words out. And it would first really freak me out of like, why can't I just talk? And her patience was really key of just saying, it's okay, we got all the time, just take your time, you'll get it. And being sensitive to the idea that sometimes I might not remember or understand a session, and she'll help me repeat that or go over that or send me text of some important components that helps me be able to hold on to it and remember it. She's really learned that kind of dance of helping me with that conjunction between the cognitive impairment and the anxiety, the PTSD, the depression, that has felt very safe for me, and knowing that she understands, she validates it, and is willing to be patient enough to help me sort it out and help me find a way to, as Jim said, accept where I am, accept the new me. And the support group that we talk about, one of the members likes to say, Kirsten 2.0. We're not the same as we were before, but we can accept our new version, find out how this new version works, and find ways to accept it.
Megan, you started to talk about humanizing the ICU. And so we heard about ICU diaries. So I wondered if you could say a few more sentences about that. And then any other strategies that you'd like to see in the ICU that might help people like Kirsten mitigate some of these symptoms or at least reduce them.
Yeah. Like I think the first thing you mentioned was ICU diary. So really briefly, an ICU diary, as Jim mentioned, is a set of notes that the bedside providers, like a nurse or even family members, write, ideally on a daily basis, that might include something like, here's what happened medically today, here's who visited you today, and here's where you look like in your recovery. I've even had patients or family members start to take pictures that they would incorporate into the diary. The rationale behind that, as Kirsten mentioned, people lose a lot of time that they just don't remember. And then in times where they're delirious, this might become times where things become delusional or people have hallucinations. And so the idea is that on the outside, when the patient gets home and when they say they're ready, that's a key thing. When they say they're ready, they can look through the ICU diary to start to put the pieces back together about what was happening to them during this incredibly vulnerable time. Some of the benefits patients, in addition to what Kirsten talked about in terms of piecing stuff together, patients have learned that they weren't alone for extended periods of time where a family actually was visiting, but maybe patient's cognitive status was just not letting them register that. Medical interventions make it clear, the understanding that, oh, this is the day I got a catheter, or, oh, this is the day I got a CT scan, so I wasn't sexually assaulted that day, or I wasn't put into an oven, for example, that day. These are the things that can help people put things back together. The reason I say folks should be ready for it when they open it is just because if people do have PTSD symptoms, we know they can tend to get worse before they get better. And patients tend to know when they're in a stable state or when they're ready to receive this type of new information. And so we say like, don't force them into opening it. Just wait until they feel like they have the resources to do. So that's ICU diary. Any other things about that, Kirsten, that I should have mentioned, or other questions about ICU diary?
I did not have one. What I know about them, I think that would be so helpful because it is so disorienting and upsetting to have chunks of time you just can't remember, or then the delusional pieces. And I've been able with my therapist to piece some things together. I think a CT scan, the red light that's there, like a laser, was incorporated into one of my delusions that I thought I was being attacked by lasers. Those things I think can help. And then that takes a little bit of the trauma out of that, when you can start to go, okay, I see where that came from. And yeah, I knew it wasn't real, but it then helps an understanding of, why did I have that? So those diaries, I think, can be very, very important. And also, I'm sorry to say, but the piece that my therapist and I have found is that we have to gently probe some of the memories I do have, because there were things that I didn't recognize. I remembered, but didn't recognize how it layered into the trauma for me. When I got a PICC line, which is a standard procedure, but having the blue sterile shield over my face and having to lay flat, when that made me cough, and I couldn't cough during the procedure, and I felt like I was suffocating under the blue tarp. I didn't recognize it as, oh my gosh, yeah, that kind of layered into the trauma for me. But I wouldn't have recognized that had we not just really slowly and gently gone through that. Those kind of things would be in an ICU diary, I would assume, and could help with that.
I wanted to ask each of you if there are topics that you feel like we haven't covered that would be really important for anybody who's listening to hear and learn about. Megan, I'll start with you. Is there anything else that you think from either an inpatient or an outpatient provider perspective that you think we haven't covered that would be really helpful for listeners to hear and understand?
I think just in speaking to mental health professionals in the inpatient space, I think one of the key phrases Kirsten mentioned was trauma informed. I see hospitals really trying to figure out what that means and how to institute that. I think I would love to see policy and additional training efforts that help embed trained mental health professionals more deeply in some of these spaces, not only to work with the patients and the families to try to protect them from some of this on the outside, but also to partner with our medical colleagues to sort of keep figuring out what that trauma-informed environment looks like. There are mind-blowing basics that you as an everyday layperson, like anybody would think, oh, that's sort of like basic, but when you get into the day-to-day as a medical provider, these things, like, it's sort of like walking around in your house, right? Like, you just forget and lose sense of that. So what I'm speaking to is, for example, always talking as though the patient is there in the room with you and can hear you, no matter how sedated they are. We know patients hear and unfortunately might partially hear and confuse bits and pieces of what gets said along the way. Incorporating family, visiting hours that are non-restricted are actually just starting to come about and like new within the last 5 to 10 years, which is astonishing to me. Basic things like telling the patient what you're going to do before you do it and then reminding them as you go along. Again, this procedure that they've done thousands of times might be the first time that this patient has had this done. And so those kind of slow explanations and warnings about what's coming can be really helpful, especially if people have experienced trauma before. I don't know, maybe Kirsten has other insights about things that can be that can be reminders taught to our bedside clinicians to sort of reduce the amount of trauma that patients might experience while they're in the ICU.
I think that is so important. And like I said, just some of those routine procedures that, like you said, it's just an everyday thing for the provider, but to recognize that for a particular person that might be traumatic. There may have been a way to do the PICC line where I wasn't completely covered on my face, or to talk me through that in a different way. I had a time when the ventilator broke and they had to use the I don't know the name of the thing, but the blue bag and bag me by hand, and talking me through that would have been very helpful, because that is a terrifying thing to be aware of, that, oh my gosh, my life literally right now is depending on this person doing this. But I know they were focused on their job, so I understand there's times it probably can't happen, but just having more understanding that the things that happen every day in an ICU can be experienced in a way that can layer on trauma, I think is really important.
And Kirsten, are there things that you feel like we haven't talked about that you really want people to know and understand?
I think a couple things. One is it's very common for those of us who've been in the ICU to feel guilt for two parts, what we put our family through during the ICU stay, even though clearly it wasn't our fault, but we know that it was very tough on them. And then the continued amount of support that we need for some of us, for me, 6 years out still, and feel guilty and like a burden at times. So we have to work through that and work through that with family. Thankfully, many of us have family that are absolutely wonderful and don't feel that. There are some folks who lose that support because of that. And so that's important for, I think, mental health providers to understand, and where support groups can come into play. The support group that Vanderbilt that I'm in, we're family. It's truly a family. We would all do anything for each other. And that has been a huge piece for me, just knowing A, I'm not alone, and B, I have these people who completely understand, and I can say anything, I can ask for help, because I've lost friends who get tired of dealing with that I'm not the same, can't do all the same things. Those pieces I think are also important to understand and to help people deal with afterwards.
Kirsten's final words remind us that the lasting effects of critical illness and post-ICU syndrome can have a profound impact on the person living with this condition, but also on family, friends, and loved ones. And bidirectionally, their misunderstanding or inability to provide the care needed or desired can further impact the individual living with PICS. Kirsten's advocacy reminds us that education on this important topic is needed for all involved. Medical providers, so they can better understand this complex constellation of chronic symptoms. Mental health professionals, so that they can provide much-needed support. The people living with or at risk for PICS, so they can have their own framework in which to better understand and make sense of their ongoing symptoms. As Kirsten said, Life 2.0. And care partners and supporters. I hope you enjoyed this episode and learned as much as I did about this important topic that impacts so many people and yet still seems to be unknown or misunderstood. If you found this episode valuable, please feel free to share. Thank you so much for listening. If you like our show, please like, subscribe, or leave a review. This helps others find out about us. Find Empathy provides continuing education. If you would like to learn more about our courses, please click the link in the show notes or visit learn.findempathy.com. While our education is free, for example, like listening to this podcast, the proceeds we receive from continuing education goes to support the maintenance of our website and the development of new content. Finally, please know that the opinions expressed by the experts today are their own. We are not financially supported by any of the businesses or resources described in today's podcast. Additionally, any advertising that is published on the episode is chosen by our podcast hosting service and not by Find Empathy. The content provided today is for educational purposes only. Please seek the guidance of your doctor or mental health professional for any questions you might have regarding your own health or medical condition. Thank you so much for listening, and we look forward to you joining us in the next episode.